And there we are live. And welcome, Dr. Smita Sinha. You are a consultant gynecologist in the NHS, and you also have your own clinic, Serenity Women's Clinic in Somerset. Welcome, and we are going to be talking and looking at some rather interesting things tonight. Let me know if you can't hear this over there. Let me just put this up over here so you can actually hear a bit better. And we will be underway. Now, it's a shocking thing that an awful lot of us don't actually even know our own basic anatomy. Shall we start with that? Would you actually want to run us through what it is we're talking about when we're looking at our vulva and the difference between our vulva and our vagina?
Absolutely. Thank you so much, Fiona, for having me. Just a slight correction, I'm just private now, so just at Serenity Women's Clinic. But yeah, so I specialise in menopause and vulval conditions, which I did in the NHS as well, and is a real passion for me. So I love saying the word vulva. I can't say it enough, and I hope everyone who's listening today will keep saying it as well and keep promoting it. So essentially, the vulva is the external part of the female genitalia. And even that might be confusing for a lot of people. So we are going to show some pictures. They are actual photos of vulvas because I do believe that it's more beneficial to see what an actual vulva will look like. They come in all shapes and sizes, just like our faces do, and there is no one size that is the right one. So I don't like to use the word normal vulva. I prefer to go with healthy, but that's essentially the vulva. And then the vagina is our sort of conduit from the external world leading up to the uterus and the cervix. So it's almost like a cylinder behind the vulva, internal in our bodies. And then at the top of that sits the uterus, and the cervix comes into the top of the vagina. So that's sort of vulva and vagina. Are we okay to show image?
I think we are. I think we're absolutely okay to show it. So if you don't want to look at pictures of a real vulva, I suggest you close your eyes now because here it comes.
Slight technical thing. So we're just going off my phone, but I hope people can see this here. So these are images from the British Society of Study of Vulval Diseases, and this is the vulva. So this is the external part of the female genitalia. Fiona, let me know if it's not clear enough.
It's clear. Except I just lost it. There you go. Again.
The areas that we talk about when we talk about the vulva are related to the labia. So we've got the labia majora here, we've got the labia minora here, and then I'll just switch to image which shows us the sort of inner part of the vulva. So that's where it just parted a bit. So again, you can see the labia minora here. And then we're coming into where we can see the vaginal entrance. This one's a little bit small here, just magnify that. You've got the hood of the clitoris at the top, and then the clitoris below, the entrance of the vagina sitting here, and then you've got your urethral entrance, so from the bladder coming through at that point, and this will be your perineum, and then going down into your anus. So that's the vulva, essentially, all shapes and sizes. But it is really important, and there's a lot of work being done at the moment to really address moving away from any kind of body shaming, any kind of taboo to do with women's health, because it's really vital to be able to explain what it is, what's going on, recognise things for yourself and for when you may be going to have any kind of health checks and visits as well. And there are some reports coming out about how actually not knowing that can be rather sort of detrimental to your health as well. So picking up on the right words and terminology is the number one thing I would say for everyone to be able to do.
Yeah, absolutely. Because if you can't explain to somebody where exactly your pain is, especially if you've got a 10-minute consultation and you can't actually accurately say, I think the pain is here, then you're getting your doctor to be doing an awful lot of guessing.
Yeah.
Looking,
sorry. That also doctors can be on the other side of this, where that they equally are humans. They may not be comfortable as well, and may not be well practiced in terms of looking at vulval health, and may equally not be using the words openly for fear of offending or upsetting people. So then you get into a situation where both sides aren't really saying what's happening.
Yes, I guess there could be a lot of ways you could interpret a foo-foo. Which bit of the foo-foo are we actually talking about there? Looking at that picture, now that is what you would have called a healthy vulva, and the colour of it was sort of a little bit sort of dark around the edges, but sort of quite nice and sort of pink on the inside. When people are looking at their vulva, how important is it for them to know what's normal, and how can they then have a look at, what sorts of changes would make you think I need to get that looked at?
Yeah, absolutely. And I think, as I said at the beginning, it's sort of looking at your face. So everyone's face is going to be normal for you. We would never come out and say, well, actually, this is the normal face and everything else isn't. So it's about starting with your normal, as we do with many other parts of the body, just knowing what's there, what feels okay, and what do things look like when it feels okay, so that you can then describe, actually, it's changed, that I've got some new symptoms and I've started to notice these areas that are occurring. So self-examination, again, as well as starting off with using the words correctly, knowing what they are and being empowered to use them, is number one. Then it's moving into self-examination, again, feeling empowered to do that, having the confidence to do that. Traditionally, again, it's not something that's talked about, it's not something that's really promoted. Even women that may attend vulval clinics may not be taught self-examination all the time, and it can form an important mainstay of your care going onwards. So checking yourself, hand mirror often is the easiest way. It's not easy for a lot of people, of course. It's tucked away and without a lot of bending and craning your neck and things like that. So one sort of solution, often you're going to have to be lying down and things, but one solution can sometimes be sitting on the toilet, popping a hand mirror onto the sort of rim of the toilet seat and just sort of angling it back towards your vulva so that you can see at that point, or equally lying down flat and checking there. And as we saw in the two images, you want to be able to look just parting the vulva and looking at that inside skin as well, because the vulva is all about the skin. So you really want to be exposing that and checking all areas of that, especially if you've got some symptoms, just to make sure that nothing's tucked away that could be leading to what you're feeling.
Okie dokie, and we will get to some of those. In terms of looking at yourself, I mean, the other thing that I do actually is I use my phone. I wouldn't be taking that to the toilet just in case it disappeared down the toilet, and that would be very hard to explain to people. Yes, I lost my phone down the toilet while I was examining my vulva, but in bed, and I just flip the camera around.
Yeah, absolutely. Yeah. Exactly. So any sort of close angle that you can try and get, or something that you can angle and see as well. I did try with dental mirrors, but they were just too small. So on an angle that can help you see.
And actually, if you use your camera as well, if there's something funny there, you can take a picture of it and sort of keep track of it over time. One of the most, when we get to this sort of, when you get to my age, darling, one of the things that people find continuously is vaginal atrophy. And if you're anything like me, you will do, because especially if you think you're sort of a bit of a smarty pants and you know everything, you will be a fool like I was, and you will spend 3 years saying it's not vaginal atrophy, it's thrush. How do we know the difference? When it's itching, what is it that, because it doesn't actually feel like it's actually turning into thrush, but it feels like it's the beginning of thrush. So it's that sort of burning, itching, kind of really annoying feeling that doesn't really go away, but you don't know what else to put it down to. How do you know when it is or it isn't thrush?
Yeah, very good question. And again, this is equally for women as patients, but also for healthcare professionals as well. It's obviously, we know thrush is the most commonly thought of condition, and that's why that comes to everyone's head, number one, followed by other infections, and that's sometimes where the barrier can come through, that people start to think that, oh, well, something's happened, someone's going to think I've been a bit naughty, and et cetera, et cetera. And that's where the knowledge and the awareness of what the vulva is really important. And as I mentioned, vulva is skin. So as we get skin conditions elsewhere in the body, and if you are prone to skin conditions elsewhere in your body, it's likely that that's happening on your vulva as well. So really being aware that if you're prone to eczema, if you're prone to psoriasis, if you're prone to lichen planus in your mouth, these things might happen on the vulva as well, and there are many other conditions. One thing to state, for postmenopausal women, you need estrogen around to have thrush. So if you are postmenopausal, you're not an HRT, there's no other predisposing skin conditions that this could be a secondary infection, and there's no sort of underlying diabetes, for example, it's not thrush, and that needs to be reviewed and that needs to be looked at. So the assumption that it's thrush and gets treated for this group of women, it has to sort of stop really. Prior to that, you're sort of looking out for the symptoms. Largely with thrush, you will get a discharge, not always. But again, it's knowing you're normal and knowing what other things are associated with it. Now, if it's a sort of turning into something that's longer standing, if there are skin changes that you're starting to notice, sometimes it's with a trial, you've trialed some canestan pessaries that's not helping, then that's when you need to either be really checking yourself or taking your information that you know and you've seen and going to see your healthcare professional around what are the other options that it could be.
All right, and let's have a little bit of a look at those, because I mean, I think especially it's great to have over-the-counter canestan freely available, but it does mean that then you can go for a very long period of time, probably missing things that should have been picked up an awful lot earlier.
Absolutely, and it's not uncommon again for me to see a lot of people come to me after having been on this journey for such a long time, and it goes through so many different stages of acknowledgement or acceptance in themselves that something's wrong, then going to see somebody around what it could be, being told it's this, it's that, trying the treatment, nothing happens, going back to square one, and then almost being brave enough to keep going with it. And that's where a lot of women, I think, will stop and just say, oh, I'll just deal with it. So in terms of so what we now will call genitourinary syndrome of menopause, it's essentially encompassing all of these areas, so the vulva, the vagina and the bladder, and it's related to hormonal status. So you're getting a reduction in your estrogen, and that's changing your tissues essentially. So you're losing some of the color in it, so the tissues may become paler. You lose some of the elasticity in the tissues. They start to become drier. They may shrink down. But often you'll see these changes that are happening uniformly. So it's not necessarily patchy. It's just the whole area is starting to change. So those are some of the things that you can notice with genitourinary syndrome of menopause affecting on the vulva.
Let me just do that for one second, because Anne here, this is actually really quite interesting, because this is so 3 years ago she used Vagifem twice a week. 2020 she was diagnosed with thrush. 3 years on, having seen a vulval specialist and a menopause specialist last Friday, she suggested she was I was getting continuous thrush because she had too much estrogen. She's on an ring and a 37.5 estradiol, which isn't really very much. She's scared to do without the string, and I would be too, because it is a game changer. HRT was started because she has osteoporosis. She has no discharge, but she has the burning. So what is there something that's been missed there, is my question.
So
without, of course, the fact that you cannot give you cannot give individual medical advice, but this seems to be, Anne's situation there seems to be quite common. I get this a lot. I have a private vaginal group, and literally I would say 90% of them say they're on vaginal estrogen, they're on systemic estrogen, but that burning just does not go. What's going on?
And with this particular lady, did you say there'd been a diagnosis of thrush that's been confirmed on a swab, or that's the suspicion?
She was told. She didn't say whether or not she's had a swab.
Okay. So it's around the regime as well. So obviously vaginal estrogen is one tool that we have, but it's about sort of basic care of the vulva and vagina as well. So we're starting off with things like emollients, for example, or personal lubrication, and that's key, really. So the vaginal estrogen that we will be getting, of course, will help enormously, but we also need to make sure there's a good foundation there. And this is often the step that I find myself talking most about in clinics, really, is the sort of more basic steps to take around looking after skin. So avoidance of certain triggers and irritants that we know about. So we don't want anything coloured, we don't want anything smelly, perfumed, and we want to try and pHs as normal to what the vaginal pH would be, and also looking at things like the osmolality in products as well, because all of these, it's
very hard to find things that even say that, isn't it?
Yeah.
She says she's on itraconazole for thrush, numerous swabs. There you go. The pH, so you're looking at somewhere, what, 3.8 to 4.5 if you're lucky. Osmolality, nobody's ever going to tell you unless it's yes or somebody like that. Hard to find.
Yeah, so it's about keeping it as simple as possible, I think. So as I mentioned before, in terms of women who are postmenopausal, if there is HRT involved, then those conditions such as thrush can come about because of that added estrogen that you're getting there. But also because all the structures and the tissues have all changed and they've gone through that various cycle with the loss of estrogen occurring, it's again going back to basics and really building up your skincare and barriers in your skin as much as possible, and sometimes even just stripping away a lot of things that are happening. So it's trying to keep things as simple as possible. And of course,
yeah, because you do find then that people just pile everything on, don't they? They've got a bit of hydrocortisone, they've got a bit of a moisturizer, they've got some lube going, they've been, basically dragged out the entire kitchen cupboard and thrown it on, and then it's really sort of impossible to work out what's really causing the irritation.
Yeah. So of course, examination is important, just seeing any features that could be more linked to irritation or more linked to GSM. Of course, wanting to exclude any other skin conditions that could be emerging and causing this sort of burning pain. And then I think also what can happen is there can be various triggers that set off a vicious cycle, especially when it comes to sensations from our vulva, so leading to cause sort of feelings of pain, can be triggered by even one episode of thrush or two, or herpes, or different things like that. You may not have that, and you may not have it again for a very long time, but that sensation of what it felt like and what it feels like can unfortunately start to become a bit of a cycle. And again, that dealing with vulval pain is also quite an important aspect when I'm seeing women and addressing what it is that they're facing.
The poor Anne, she's saying she's 65 and she can't believe she's going through this. In a case like that, then if the estrogen is contributing to postmenopausal thrush, would it be more sort of sensible then to swap to an intrarosa or a DHEA one, or a bliss cell or something like that doesn't contain any sort of glycerins? Is it worth sort of swapping around then so she's not taking everything away, or a spermifene, something like that? That is other alternatives she could look at so she wasn't without.
Yes, because it seems like obviously the reason the estrogen was put there in the first place is now getting sort of all of this negative feedback around it. So trialing possibly without that, and again, as I said, it's not possible to give individual advice, but depending on what has been trialed beforehand, but certainly either trialing without that, because whatever is happening, it's countering the effects of the estrogen right now, and again, taking it back to basics, what's happening when there's nothing there, does it all settle down, and then looking at what options, alternative options there could be to try at that time. But equally looking at, is there anything else that you could support the skin with, as we said, with your sort of self-care, with the right types of emollients and lubricants as well.
The other thing too is we had a question that came in from the promo saying, I'm using Avestin twice a week. It doesn't feel like it's enough. And often women are told a variety of very, very interesting things, like there's no point in you using Avestin externally because there are no estrogen receptors. You can only use Avestin twice a week because if you're having a systemic HRT, because that will be too much estrogen. Are there any truths to those sorts of things, or can you, if you find you are still having issues, bleeding, tearing, unbelievable discomfort and so on, can you quite happily use it more often than twice a week?
So again, I think it comes down to the issues around thrush treatment. You want to make sure that there's nothing else underlying those symptoms that you're getting, especially with the tearing and fissuring and things that can occur. But if all of that's been excluded, it is genital urinary syndrome, menopause. There's lots of evidence, which the British Menopause Society supports as well, that the topical use of estrogen is very safe, and the amount that's going to get absorbed equals the equivalent of 1 tablet of estradiol. So using topical estrogen the whole year through, the amount that's actually coming into your body is only the equivalent of one tablet. So really, if you want to use it every day, that's absolutely fine. It's around just sort of understanding what works for you. But as I said, making sure that there's nothing else underlying it, because it should be working. And if it's not, then you want to just check and see, is there anything else that's present?
Yeah. Other things that can be present, dermatitis, that's an interesting one as well, with lots of people getting lots of sort of irritation. You mentioned there's self-care, things like, picking a laundry detergent with no fragrance, does that sort of thing help? And the other people, I've been given hydrocortisone, I'm scared to death of putting this anywhere near my labia because of skin thinning. Can they safely use it for a short period of time just to get that dermatitis under control, or is it off limits?
Yeah, absolutely. So, I mean, thinking back to the image of the vulva that we saw at the beginning, I could probably talk for at least half a day on different conditions that there are, but to keep it simple, I would suggest that people, when they're looking at their vulva, if they think something's changed, it's 2 things to identify. Does it look white? Does it look red? And I'll just show you. So when we're talking about things like dermatitis, it's more around red. So we're going to show another picture of the vulva for anyone who wants to look away. So this, if we've got it here, this is around the labia majora. Sorry, it's a little bit blurred, but you can see you look at that and you see there's redness. And
yeah, it looks a little bit sort of pink and irritated at the bottom, doesn't it?
Yeah, it doesn't need to be sort of bright red, bright pink or anything like that, but you've started to get that change. You can probably also see it looks a bit thickened. This has probably been a bit chronic. So we get what's known as lichenification, which is the thickening of the skin as someone is scratching repeatedly over that skin. So if something looks like that, then it's likely a contact dermatitis or eczema. So again, you want to exclude any eczema in the rest of your body, and look at any triggers. So a large number of women may not be able to identify these triggers. It can be tricky, and may need patch testing if things aren't settling it down. But on the whole, you want to go back to removing the trigger if you know what it is. So as we mentioned, you don't want any, dyes can cause it, changes in your fabric, a detergent, anything that's going into them, biological powders and things in your sanitary towels, perfume, and your toilet paper. All of these things you want to try and assess and make sure that they're as simple as can be.
What about sweat?
Yeah, I mean, it's skin, so it's coming into so many different things. So sweat, urine, feces, semen, all of these things can be affecting that area. So that's why emollients can be good, because they're providing a barrier, essentially. So if you are prone to getting these sorts of skin conditions, it's around looking at trying to give your skin a barrier so that it's not getting triggered, it's not coming into contact with things. And it can be tricky because some of the contact can occur at a one-off episode, and it might not, like other skin conditions, it might not present itself for a couple of weeks later. So condoms can be a big culprit of this. People may not link the two together because it doesn't start to happen till a little bit afterwards, or you get a bit sensitized to it, and then that causes some of these changes.
Did not know that. There you go. Undiagnosed latex allergies and those sorts of things. Crazy stuff. So back to the hydrocortisone in point then. So if somebody says, okay, try a bit of hydrocortisone for a week just to get that down, is that an okay thing to do? Should people not be frightened of that?
Yeah, absolutely. So I think data around the use of topical steroids has been around for 60 years or so. And I think
You're frozen on me.
Oh, can you hear me?
Yep, I can hear you. Yep.
And then around 91, the use of ultra-potent steroids was used for lichen sclerosus. So we've got a lot of data around the use of steroids, especially on the vulva. It is being used on skin that is got a condition, and that's the way I like to explain it to women, is that it's going on skin that's already got a process occurring, and that inflammation, that inflammatory process needs dampening down, and that's where the steroids can help. And using half a fingertip to a full sort of fingertip amount on the area, dependent on what's been advised by your healthcare professional for that period of time, is fine. What we don't want is women being on steroids unmonitored for months and months and months, or years and years and years. So that's where the self-care, the self-examination also comes into it, but that you're wanting to be able to have follow-ups to review. Because if that's not working, then you need to go back to square one again.
Yeah, the in terms of if you were using an external of Avestin or something like that, and you were going to use a hydrocortisone cream, does it matter which order you put them on in, or should you put them on at separate ends of the day, or is there a rule to follow there?
So I think traditionally, with both of these things, you may want them on last thing at night to give you that soothing. So it depends on when your symptoms are arising from many of these things. You will want to separate the use of them by sometimes to allow each product to absorb and affect in the way it is. Now, the skin in the vulva is going to absorb things reasonably quickly, so you want to possibly pop your hydrocortisone on first, and then you can leave it for half an hour to an hour and then pop your Avestin on. If you can split it and your symptoms arise at different times, then maybe last thing at night or first thing in the morning, or after you've showered and everything, popping one on then and the other at the other time. Emollients can be at any time, so again, use in the bath or the shower. And equally, when you've been to the toilet, I always advise once you've wiped, pop on a layer of the emollient after that time as well. So then you've got a fresh round of sort of barrier protection for the next couple of hours with that.
Yeah. In terms of emollients, I see a bit of an argument every so often with some people saying dermal is great. Have a tub of dermal 500 everywhere in your bathroom and it's absolutely fantastic. And then others going, oh my God, no, don't use dermal 500 because it's going to kill your natural microbiome. Any truth to that? Or are there some cases where dermal is actually great but not for everybody?
So it's got that property in it. So I think if there is something underlying the trigger of that particular skin condition, then it's worth considering that use. So again, it's all individualized to what properties will suit that particular condition at the time. I don't know if I'm allowed to say what my favorite go-to is, but
it's up to you. As long as if you are being paid to say it, as long as you declare that. If you're not and it is just actually your favorite, go crazy.
Yeah, so no declaration. But my favorite tends to be Hydromol because it's got a good, especially the ointment provides, it's got paraffin in it, and we know there are certain ingredients, again, that I'm not too keen on, but in terms of the external skin on the vulva, then it's giving a good barrier and providing that soothing amount without anything else really being in it. So in terms of colours and other properties that are going to change the skin's flora. So that tends to be my go-to.
Is it, you mentioned, some people don't like paraffin. I'm just going, actually speaking of things, I'm just going to This is one that Vulval Cancer Awareness recommends, actually, because it is actually just literally a paraffin spray. You can carry it in your bag, and you don't have to touch yourself. You can actually whiz to the loo if you're feeling sort of irritated and uncomfortable. Give yourself a quick squirt and sort of disappear. But then some people go, "Oh my God, paraffin liquid!" I mean, obviously you don't want to be standing next to a naked flame, which you probably wouldn't normally be doing unless you were going along with Gwyneth Paltrow to do a bit of vaginal steaming or something. Other than that, you probably wouldn't nearly be near a naked flame. But why do some people not like the idea of paraffin liquid? And by the way, I don't get paid anything for showing that. I'm just showing you how to have it. So why do people not like it?
So I think it's a sort of issues around the use of glycerol products, and the change that you may see within your flora, essentially. So I would agree. I would say if you're looking at your vaginal products, so the products that are going more against what's known as squamous mucosa, you really have to be careful about the level of absorption of the product going into over that type of skin. You've got still some level of barrier because there's hair follicles and things like that over the vulva, which will help a bit more. But I would say vaginally, probably agree, just looking at and products that are pH balanced, and very carefully looking at your osmolality, because if we go back to what osmolality is, so if you've essentially got two products next to each other, one is hyper osmolality, has hyper osmolality, and one is your iso, which is the neutral part. Your fluid, your hydration is going to go into your hyper, so you're going to actually take the moisture out of your skin, and it's going to go the other way. And that's why you want a hypo or an iso, which is, as we were saying before, is often not declared. And a lot of products may find it difficult to achieve that, or may not even be looking for it. But we know with
vast majorities, Nick Panay and Edwards, and I think Naomi Potter as well, did a study on this, looking at it, who recommends that osmolality should be somewhere around the 380 mark, I think, from memory. And I think there was literally only one or two products that even came close to that. They do say up to 1200 is sort of acceptable, but even then the majority of vaginal lubricants and things fell well above that even, which is really scary.
And you just imagine you're just drawing all of that hydration out from where you actually want it to be. So yes, it'll be sitting there in that product, but it's not doing anything great for your tissues. So I would definitely agree in terms of vagina, I would sort of stick to and products like that. I think you've got a bit more give with the external seal on the vulva itself, and then it's just looking at some of the other properties that would be helpful for the symptoms that are occurring, but still keeping it.
Yeah. While we're at vaginas and lubricants and those sorts of things, there seems to be an awful lot of hype around at the moment about coconut oil. Sort of like, it's cheap, it's accessible, it works, use your coconut oil. But we don't actually have any studies really on coconut oil and vaginal tissue. Do we know that it's actually safe?
No, we don't have any studies. And again, I think it's around acceptability of what people trust and want to use. So something being natural might be more acceptable for people. And it's just around also just having that suitability of what suits that person. So actually, if that is suitable, it's soothing their symptoms. And no, we don't have research. We're probably not going to get that level of research that we need to answer that question, because the parties that are involved, I don't think will get anything from it, unfortunately. And that's sometimes how it all works. But
unless you support the Menopause Research and Education Fund, and we will be doing independent research on exactly those types of things that people think don't matter. Anne has another little question here for you. She says she's using Emmeline, which she loves, and she also uses Epiderm first thing in the morning. Can she use both, and does it matter what order she would put it on in? I would assume you'd probably go Epiderm first, then Emmeline afterwards.
Yeah, so Emmeline, I haven't come across Emmeline, to be honest. That was a spray that you just showed us. Yeah. Would imagine absolutely put on the Epiderm first, let that absorb, and then the Emmeline can be used almost as a top up. It's sort of like your sunscreen in some ways. You sort of get that layer on first, and then you top up during the day with a spray or another layer as well.
Yeah. When we get to things that are starting to go a little wrong, what are we actually looking for? I mean, one of them, because it's very hard to actually get somebody to have a look at your vulva. Are we underdiagnosing lichen sclerosis? Are we seeing more lichen sclerosis now when we are looking? What is it, and how do we look after it?
Yeah, so again, got an image because just to be able to identify things. So as I was saying earlier, when you're self-examining, to understand the changes, and some of the simplest things to maybe look out for is what color are things. So in lichen sclerosis, typically, unless there's an aggravation of things going on top of it, things have gone more towards the paler or the white appearance. So this is a diagram of what lichen sclerosis can look like, as well as that.
I mean, some bits of it look quite angry and other bits look very pale, don't they?
So we've got sort of the paler areas here, but also importantly here is that we've started to see changes in the anatomy. So
Absolutely.
this is
It's almost like there's zero clitoris there, and you sort of always looks like it's scarred over the entrance to the vagina.
That's right. And again, these are all images courtesy of the SSVD. So knowing your normal is really key, because, and especially for maybe some of the older women who, again, might be in that situation where they've never thought of looking at their vulvas. They may have had lots of different over-the-counter treatments and things like that. And it's not uncommon to see women of that sort of age group coming and presenting and having quite advanced lichen sclerosis. So this is why it's really key, I feel, so that people know what their healthy vulvas look like. So it's most likely autoimmune. That's the condition that we attribute it most in. Autoimmune, it's a chronic condition. And affecting between, we think, 1.7 to 3 in 100 women. So yes, I think largely underreported because a lot of people are not getting examined, not identifying that the symptoms they're having could be causing a problem, not looking and not going to be seen. And equally being seen and maybe not being sort of diagnosed correctly either, and then having their pathways forwarded. So the women that we see,
I mean, apart from the way it looks different, physically, what symptoms would actually make you take a look?
So it's that persistent itching that is just going to be chronic. It's quite distressing for women, the type of itching that you will get with these skin conditions. So lichen sclerosis is one of them, equally lichen planus, and numerous other ones as well. So these conditions are the ones that it's intractable itching almost, and it's not being settled by anything that's been given over the counter, for example. Sometimes what can end up happening in these situations is that they will get seen, they will get assessed, they're offered treatment, but it's a course of a steroid treatment. So it's a really potent steroid called Dermavate, but it's the right treatment for this, even though it's potent. Again, it's not to be scared of. As you can see from the changes that have occurred, this skin condition really needs that high level treatment to be given to help reduce the inflammation that's going on the cellular level.
If it's autoimmune, why then do they not use autoimmune type therapies as well in conjunction with it?
So you can, I mean, in intractable cases, you can go on, and there's a lot of research going on in terms of future modalities to help with lichen sclerosis. But so you can go on to using certain, but you want to go with, they're quite strong medications which will work for autoimmune conditions. So you want to go with what will help and what will work. And it can be with the right type of compliance that up to sort of 96% of women will be helped with the topical steroid. So it doesn't need to go to more of a systemic treatment. But for some women, around 10%, and depending on what compliance and things like that is like, you may need to start looking at some of the other medications that will help from that level. So tacrolimus, for example, can be used in certain situations. Vulval conditions, when it comes to this sort of stage of things, it's very multidisciplinary. So even I would want my dermatologist colleague, in certain cases, a urology, so the ones that look after the bladder. You may need to speak to a bowel specialist depending on other conditions that are arising. So if you're needing to step into these things, then you're probably wanting to have quite a multidisciplinary approach to make sure that the care and monitoring is as it needs to be because of that sort of treatment. But for the majority of cases, if it's been identified, it's not a cure, it's a maintenance and it's a management of it, but it can be managed well with the use of good sort of self-care regimes, emollients and things, as well as the use of Dermavate. And an important thing that I, again, like to say for people who have lichen sclerosis, they don't all need to be managed in secondary care, so with specialists. They can be managed by their GPs, and there are certain pathways to look at in regards to that. But it's a maintained use of the Dermavate, and that's sometimes where we get pitfalls. People will go on it for 2 weeks, and then they'll come to see a vulval specialist, and they said, well, I tried it for 2 weeks and it was great, and then I was told to stop it. So no, we don't want people to do that. This type of condition that's autoimmune and it's chronic has really probably been developing in the body for years. It's not happened overnight. So therefore, a 2-week course of a steroid is not going to do anything.
Yeah.
You want to begin with of at least 3 months. And actually, for me in the private sector, I would see somebody back at 6 weeks after starting treatment to see how they're getting on and what else needs to be done.
Now, speaking of what else needs to be done, here's another thing that doesn't have a lot of studies behind it, but people seem to be saying that they're getting good results with it, and that's PRP. What are you thinking on that?
I had a feeling you were going to bring this up. So
I love to throw the left of field ones in.
Indeed. So I went to the BSSVD conference in March, mainly because there were talks around PRP, laser, and all of these other modalities that are coming out. Dr. Aurora Almadari is doing a study which is hopefully turning to a multi-center study, PEARLS, which is going to be looking at lipotransfer and PRP. So I think at Royal Free, they have done studies as from looking at fat transfer. So not necessarily PRP, which is platelet, but the fat level. And again, it's not conclusive, but there are promising results coming from it. So it's a watch this space.
And there will still be some growth factors in that fat transfer.
Yeah, and I think, as we know with many of these skin changes, there's a loss of collagen and things like that as well. So it's looking at all of these aspects, and they've certainly seen an increase with that in the preliminary studies that they've done, but obviously more, and also looking at the use of that versus a sham procedure and things like this all need to be considered. So I believe a further study is in design process at the moment.
Oh, brilliant! That's good. Yeah, because I mean, logically, you would think that it should, in theory, help, because if it helps improve blood flow, if it helps improve, neural endings and those sorts of things, you'd think that somehow anything that improves the blood supply would possibly help improve a tissue and help reduce sorts of nasty things. So it makes sense in some ways, but yes, just not an awful lot of evidence yet to back it up, apart from reports.
It is being done privately. It's not something that I do, but we know that these procedures are being done privately at the moment, and it's around, I think it's informed consent at the end of the day. If a situation has got to this extent, then it's around really making sure you're going to see the right practitioners who've got the right knowledge around.
Oh, I've lost you again.
Oh, can you hear me now?
Now you're back. Perfect.
Just knowing and doing your research, if you're going to have things like this done, that they have the backgrounds to assess your condition and are aware of the sort of underlying pathophysiology and everything. and having that informed consent around realistic expectations from what the treatment may or may not bring you.
Yeah. In terms of those sorts of things, actually, as well, the market seems to be awash with handheld. You mentioned lasers here, so just pick it up on that one. Handheld laser devices that you can use in your own home. Not even just laser devices. We've got, I think, LED lights. We've got lasers, LED lights, radio frequency, and now there's even a new plasma one, which is like, oh my God. Does there need to be better regulation around this market, for want of a very direct question? Because I just kind of think the idea of heating my vaginal tissue up to 40 to 42 degrees, 44 even, in the privacy of my own home, especially if it's got a nice little vibrating thing that goes along with it just to make it extra fun, could be really potentially very dangerous.
Yeah, I think these at-home devices are definitely something that need to have, a regulation around them. But again, this is the difficulty we end up in when we are in such a poor state of research around what is working and what isn't. Is that obviously these novel treatments are coming out, and people obviously will want to try if they've got to that stage where they just need to try something. I think it's the same as, laser treatment for your hair that can be offered in a salon. With
Laser treatment for your hair?
hair removal.
Oh, I was like, oh, that worked.
Hair removal with laser. So, you can go to a salon with a regulated practitioner who's going to perform that for you, but we know that they're available at home as well. And I think that's what a lot of people will consider, is that, well, that's available in a salon or at home, and so is this.
It's a fraction of the price. And
yeah, absolutely. But I think, again, it's really, as with everything, it's understanding the limitations of the product, sort of questioning actually what could the issues be around it, asking the manufacturers or the companies that are selling it of any reported incidences as well, and just keeping yourself safe.
That's the thing, there would never be any reported incidents as well. A, there's nowhere to report it. B, if you ring the manufacturer, they're probably not going to, there's no onus on them to actually say there's anything that's gone wrong with their product. Why would they? No, extraordinary. And the other thing, actually, you mentioned collagen there. I noticed on the weekend an ad for a collagen supplement for your, and I quote, lady parts. Is there any evidence on this planet or any other that having a collagen supplement will fortify and regrow the collagen in your vagina specifically, or anywhere else in your body, really?
I don't think you'd be able to target specific areas. That would be my comment on that topic. I mean, it's not something I've seen. I'm intrigued to have a look at this, but
you will love it, I'm sure, probably almost as much as I did. As I did the endless scroll through the clickbait of I had this dreadful problem, and it was absolutely awful, and I couldn't solve, and I couldn't find any product anywhere in the world that was right. So I formulated it with all of my experience myself, and I've solved this problem for $39.99 a month. I can solve your problems too.
Yeah. And it's around, it's the whole sort of education around sort of fake news and things like that, is that we are at a point now where we can go in either direction. And I think it's things like, as we've shown pictures of the vulva, it's really knowing things for yourself, and being able to turn to people like yourself to get the right information, and clear information as well, in terms of what's available out there, because there's anything and everything available out there.
There certainly is. Exactly.
And I think, let alone if we go maybe to other places where there's even less regulation going on. So yeah, I think a key thing is more research, so we just know what are the safe parameters to be within, but also reaching out, double checking something if there's not a manufacturer, someone bombarding you with questions and things, but all these social media accounts and things as well, just running something by someone that you trust.
Yeah, exactly. A couple of things that we should touch on before we run out of time. Vulvodynia and vestibulitis. What are they and how do we look after those?
Yeah, so I tend to say vulval pain, again, because it can be almost a part of the whole condition in terms of giving it a label as such as that. So vulval pain to encompass all of these situations. So really you're looking at lesional or non-lesional. So if there are skin conditions like some of the ones that we've seen, or some of the other ones that cause ulcers and blisters and things like that, then yes, they're likely to give rise to pain. So one of the key things you want to do if a woman presents with vulval pain is examine again and check. It doesn't have to be an internal exam. You're not checking the cervix or anything. You're looking at the vulva to see is there anything causing it, and then you've got your non-lesional pain. So the vulva will look healthy. There isn't any particular issues that even the women themselves can identify or suggest that this is the area that's causing me concerns. And then it's understanding that the nerve component to the vulva, as well as the skin, the muscles, everything like that's in that area is hugely complex, quite diffuse nerve endings. So we don't have specific nerves going from one area to another area. It's covering quite a large area. So we get what we know as referred pain. So again, this is where it's quite multidisciplinary. So you're wanting to look at someone's history of what it is that's concerning them, but also delving into their former history. So looking at any history to do with gynecology, any history to do with urinary symptoms, with bowel symptoms, with skin conditions, lots and lots of different things, not to mention emotions, and a sad and unfortunate fact that about 20% of women may have had some form of sexual abuse, which is, really traumatic, and can evolve and present itself in different ways. So it's quite intense, these sorts of consultations and discussions that you want to be able to have to try and tease that, and may often need a lot of time and multidisciplinary support with things as well. In terms of treatments and things, it can vary depending on where largely we're looking at some of the causes. So if we're strictly looking at non-lesional causes, so there's no skin issues there. Again, self-care and keeping your skin optimal with your regime is number one. But you're looking at physiotherapy, even psychological support to tease things out. There's a brilliant resource that I was going to share, which has been done by Claudia Casari. She has done the first PhD in vulval pain. And fantastic resource which we partner with at Serenity Women's Clinic. Sorry, I don't know if that's flipped or not.
No, that's around.
So it's called FemSpace, and it's a digital care and support system, self-support system that you can use for education around pelvic pain, vulval pain. I think they're introducing one on endometriosis as well. Evidence-based. So really, it's a fantastic resource, because even in the private sector, with the longer appointments that I can offer, it's often not enough. You want to be able to give women resources, because these women really want to help themselves as well, of course, to go away with and work through and gain that awareness as well of what could be causing things. So it's quite difficult to say in a nutshell around pelvic pain. We'll probably have another one.
Yeah, absolutely. Yeah, there's a whole nother question. Anne has one more question here, actually, and it's an interesting one. Fordyce spots. The gynecologist said she had them, but she doesn't feel them now. Feels slightly rough. They're quite often on scrotums, aren't they? These are the little red, from memory, little sort of look like little blood vessels.
So yes, so again, because the vulval skin is made up of different components and different layers, you can get some of these little lumps and bumps that appear to sebaceous cysts as well, that can come and go. skin tags and things, and Fordyce spots can be part of that. So they're benign, and it's, again, can be sort of troublesome whilst they're present, but they should settle down as well. And it's a matter of just making sure that if it's not, or it's getting bigger or anything like that, that you've got the right diagnosis that's there. But they wouldn't need any specific treatment for it. You're more likely to do harm if you try and remove it or do anything else with those kinds of skin. So you want to sort of leave it to settle by itself.
Yeah. I have one last bugbear question for you, and that is the constant marketing we have at women about vaginal laxity. Now, as I understand it, once you reach sort of menopause, your vagina shrinks. It doesn't become a gaping balloon that seems to flap around in the wind. So why are we being told that we suffer from vaginal laxity?
Yeah, I think it's part of the treatments that are being looked, or we've discussed in terms of laser and radiofrequency and things like that. A disclaimer, which I do provide radiofrequency treatments. But again, it's around the right sort of consultations and the right discussions. And vaginal laxity, I would probably attribute more to somebody who's premenopausal and maybe more around stuff. So it is one of those treatments that, being a gynecologist, I do feel comfortable to provide, because it's more around the consultation than actually providing that treatment, and getting the right treatment for the right person with informed consent and awareness and expectations. What some people might maybe confuse it with is the labial changes, in that if the vagina and the vulval sort of base tissue is shrinking, for some people the labia may not as much, and therefore they'll get a disproportion. But again, it's around the education that there is no such thing as a normal vulva. It's around the healthy vulva. But equally, everyone, as we do with the rest of our appearance, knows what they're comfortable with and isn't. So as long as within your consultation you're sort of discussing and delving into all of this, that it doesn't have to be that there's a conformity around it, but actually if this is something that's making you feel as uncomfortable, then it's available. And I certainly would offer it to people who may be considering labiaplasties surgically, that this is an alternative. So if someone's already got to that stage of that's the treatment and that's the management that they want to look at, then I think providing it with a non-invasive option such as radiofrequency is something that's definitely worth considering.
Yeah, it's an interesting one, isn't it? Because again, it's another one that doesn't have a huge lot of evidence behind it. But I've had the radio frequency treatment, and the reason why I had it in the end exactly was because of that external issue. Literally for years, because obviously I ignored the atrophy for many, many years. But even with estrogen, I could barely walk. I could hardly sit. Every time we'd go for a walk somewhere, I was constantly having to duck behind a tree and rearrange myself. It was unbelievably uncomfortable. So when somebody said, "Would you like to try it?" I thought, hell yeah, I would actually like to try it. And I remember actually after the first treatment walking across the park towards home, and I got halfway across the park and I thought to myself, oh my God, this is the first time I've actually walked more than 100 meters and not thought about where my labia was for years. It's not that it actually physically made it look particularly different or anything like that. It didn't I didn't turn into a Barbie doll. But somehow, very, very quickly, it made an enormous difference. And that was probably, I think it was pre-COVID, and I'm still in a pretty good state. So I was impressed. So I would like to see more good studies on that, because I think that, throwing the baby out with the bathwater on things is probably not a very sensible thing to do, really. We have a question here from Ilsa, who's saying vulval cancer. So what are we looking for if we're looking for early signs of that? We've got 2 minutes.
So with underlying conditions like lichen sclerosis, there is a risk of progression. Between 2 to 4% of women who have lichen sclerosis could progress to having a vulval squamous cell carcinoma, and that's why maintenance of treatment and self-examination is important. But again, it's that disproportionate itching. Possibly you may notice if you're self-examining that there is a new area, even an ulcer or a sore or a bump that's not settling. There's discoloration or depigmentation. The tricky thing with it's now called HSIL, not VIN, but is that it can present in a multitude of ways. So really it's about just being something that's persistent, it's not settling, then this is why you need to have a check with a healthcare professional to have a look at the area. And sometimes if it's not clear, that biopsies need to be taken to confirm what is happening as well. So all comes down to self-care, knowing the terms of what it is you're explaining, where is the problem, and getting your sort of points across as much as possible.
Brilliant. Well, that was a whole karmic circle then on that. So we are up to the hour. Thank you very, very much. Where do people find you should they wish to find you?
So I'm at Serenity Women's Clinic. So it's the same Instagram handle as Facebook, and the website as well as just www.serenitywomensclinic.co.uk. And we're based in Taunton in Somerset. So it's a lovely part of the world.
Wonderful. And thank you very much. And of course, people, if you want to see more research done on these types of things, please give to the Menopause Research and Education Fund, mref.uk, because we need your support to get these sorts of things, all of these issues around menopause, well and truly sorted out. I shall end that here, and thank you again, my lovelies, and I will talk to you soon.
Thank you so much.
Thank you.